Good morning, good afternoon, good evening, everyone, and a very warm welcome to this new edition of the IACH Educational Webinar Series. I'm Mohamed Mouti from the Sorbonne University and Saint-Antoine Hospital in Paris in France, and it's my pleasure to moderate this very special webinar. As today we turn our attention to a rapidly evolving and highly promising area of translational oncology, liquid biopsies, with a special focus in lymphoma. And as the field of hematologic malignancies moves steadily toward precision medicine, I believe liquid biopsy technologies, whether including circulating tumor DNA, cell-free nucleic acids, circulating tumor cells, and many other biomarkers, all of these are transforming the way we approach diagnosis, risk stratification, disease monitoring, but also response assessment. This webinar will be delivered by a leading expert in this field, namely Professor Ash Alizadeh, who is a professor of medicine in the Department of Medicine at Stanford. He's a medical oncologist and takes care of patients with aggressive lymphomas, but he also runs the cancer genomic program at Stanford, and he is probably the right and best person who will help us understand how liquid biopsies are currently being used in clinical practice, the challenges we still face in standardization and interpretation, but also the exciting future prospects this tool holds for patients. So we're very honored to have such an outstanding speaker with us today, especially the day before, the big weekend in the United States, the 4th of July. And we look forward to a lively and informative discussion. We'll have a live Q&A at the end. So I would say, let's begin. Professor Alizadeh, the floor is yours. Welcome and thank you for joining us.
Thank you, Dr. Moti, for the honor of the invitation, and it's a pleasure to be with you all. I'm Ash Alizadeh, and I have the task of sharing with you the case for lymphoma in advancing liquid biopsies. Just as a matter of some business items, here's my financial disclosures, including my intellectual property obligations, my consulting relationships, my equity relationships, and research support. I will not be talking about any of the findings except where I specifically mention them that relate to work from these companies. I will focus primarily on academic results from my own lab and other labs. So as Dr. Moti mentioned, the concept of personalized cancer therapy is pretty far advanced today for across a range of human tumors. And we're all used to this concept of tumor genome profiling for precision diagnostic therapeutic selection based on the genetic characterizations of tumors, and now increasingly based on the composition of the microenvironment to personalize therapy. But increasingly, we are learning how to get a window into these same tumors through the blood. And as Dr. Moti mentioned, there are many analytes in the blood that we can focus on. And this is a seminar for hematology. We're used to this in the context of intact circulating tumor cells for blood cancers that circulate, leukemias in particular. But I will primarily focus today on the concept of circulating tumor DNA and the use of the blood as a liquid window through which we can observe the tumor cells. Of course, the idea of accessing the blood through DNA um, uh, as a window into tumors has a long history. In fact, 40 years ago, even before the application of the polymerase chain reaction, work from several groups showed that direct detection of B-cell lymphomas was feasible by in situ hybridization strategies without PCR. And with the advent of PCR, the recovery of recurrent rearrangements like the 1418 translocation, that's the prototypical event in follicular lymphomas, was readily detectable in a fraction of patients. But these methods did not take hold for many key hematologic or oncologic milestones in patients, in part because for many of our patients, the disease does not circulate in intact form at the clinically difficult milestones in the context of minimal residual disease, et cetera. So I'll be talking to you about an alternative strategy in lieu of detecting intact cells, whether using PCR and in situ hybridization through DNA. And the idea of doing so across a range of milestones in the management of a patient with lymphoma, whether it's at diagnosis, through the course of frontline therapy, in the interim assessment of response, in the context of continuing that therapy at the end of therapy, and then in the context of maintenance therapies, with the much of what I'll talk to you about is research towards clinical practice changes, and only briefly touch on the practice changing findings that are now being incorporated into practice in the United States and perhaps with time in other parts of the world. With this key application using circulating tumor DNA for patient selection, and in borrowing from our sister diseases like myeloma, like acute leukemias, and like CLL, to try to learn how to use ctDNA as a surrogate endpoint for accelerating drug approvals. And I'll begin at the first part of the disease, which is at diagnosis and the frontline therapy. And I'll share some of our own experience with response monitoring and the clinical challenges that we focus on for the most common aggressive lymphoma, diffuse large B-cell lymphoma. So one of the first efforts that we undertook was to develop a technique that you may or may not have heard about called cancer personalized profiling by deep sequencing. There's a collaboration between my lab and Max Dean's lab at Stanford, with the concept being that for a population of patients with a given cancer, one can identify the part of the genome that has the most recurrent mutations in a small region that maximizes the number of mutations for a given patient. And once that can be done from cancer genome characterizations and a library is constructed, a few hundred kilobases of the genome can be identified that target a few hundred genes, including the recurrent translocations, to yield hundreds of mutations when the DNA is sequenced at very high depth. When this method is then applied to a patient to find mutations at time of diagnosis or first relapse, for example, sequencing of tumor tissue as compared with matched leukocytes could be used to identify mutations for later recovery. And this same exercise can be done using pretreatment plasma for non-invasive, fully non-invasive genotyping of the tumor, such that a personalized mutation profile can be derived in silico to then allow for tracking of mutations in the blood plasma in later time points. And I'll use data from this approach, which we published over a decade ago and has kind of become a prototype for many of the liquid biopsy assays offered by many companies now as a framework for targeted panel-based sequencing and monitoring. Our first experience with using CAPS-seq was led by a very talented graduate student and later postdoc in the lab, David Kurtz, who's now on our faculty at Stanford, starting with a group of about 217 patients from North America and Europe, from 6 sites, and focused on about 800 or so specimens profiled by the technique I mentioned to you. The patients were separated into a discovery and validation cohort, and the demographics, prognostic indices, and therapeutic selection of these patients is depicted in the table on the right. As you can see, these patients have a range of stages, prognostic scores, and ages, representing the heterogeneity that we're used to in management of the disease. And what David discovered in analyzing these patients is something very interesting, is that the baseline levels of circulating tumor DNA are strongly related to the existing measures of disease burden, whether we consider the Ann Arbor Lugano staging system, whether we consider the prognostic index in lymphoma, or the glycolytic metabolic tumor volume as measured by glucose-based FDG PET scans. And all of these correlations were notable for not just being correlated, but within each individual group of patients with a given stage or a given prognostic score, we observed substantial variation, orders of magnitude variation. So thinking about patients with 1 cancer genome per ml up to 1 million cancer genomes per ml, you have a very wide dynamic range. And of course, because this dynamic range measures tumor burden, David found that there was correlations between this measure and clinical outcomes. In fact, if stratifying patients based on this into a high and low group using a threshold that's now been validated by many groups of about 300 or so cancer genomes per ml, patients could be stratified into high and low risk groups. And you can see about a 2.5-fold hazard for event-free survival in both of our training and validation cohorts for this measure of tumor burden. And this was an interesting observation because it showed to be independently prognostic of the other variables that I mentioned to you, the stage of disease, the IPI, and so on, and to be so prognostic as to be stronger than any of these. Now, why is this relevant? Well, a significant variable has been defined in aggressive lymphomas called the diagnosis to treatment interval. And this is a concept that was first advanced by the group at the Mayo Clinic, but now validated in several large studies, including patients from France and the rest of the world, where patients with a short time between the clinical diagnosis of lymphoma and the delivery of treatment are found to have adverse clinical risk factors and inferior outcomes. Now, what drives this short time? Of course, some of it is the clinical urgency that compels the oncologist or hematologist to say this patient needs to be treated immediately, but also can be confounded by logistics and unrelated factors for how far they live from the hospital and whether their insurance approves a treatment or not. So these are 2 unrelated issues that seem to compete for how they influence that time. And we didn't know which one of these was primarily driving this phenotype. And we know that this variable confounds our clinical trials because patients with inordinately short DTIs are infrequently participating in clinical trials due to the extensive screening processes and consent factors that are required that inherently guarantee longer and diagnosis to treatment intervals. So we wanted to take these factors apart and wanted to see if we could measure disease burden more objectively using circulating tumor DNA. And to do this, we reached out to colleagues from Germany and the rest of the world and profiled patients from clinical trials and the real world setting and compared the circulating tumor DNA levels on the y-axis to the time between diagnosis and treatment. And we observed a modest but significant correlation between these two factors. In fact, if we were to say we wanted to predict patients who need short therapy within 2 weeks of diagnosis versus longer, and we considered the prognostic factors like IPI versus circulating tumor DNA, we found that this could be substantially better predicted with circulating tumor DNA than the prognostic variables. In fact, when looking at how patients did, patients who had short diagnosis to treatment intervals, of course, did less well than those with longer time intervals, as predicted from the prior studies. But in stratifying the very same patients using circulating tumor DNA, we found better stratification. So um, this shows us that circulating tumor DNA could have utility to stratify, minimizing potential selection biases in prospective clinical trials as a concept for baseline measurement of tumor DNA. In fact, in univariate and multivariate analyses, circulating tumor DNA was the strongest predictor of adverse outcomes when considering IPI and the diagnosis to treatment interval. So what are some examples? This is a study in the UK using circulating tumor DNA at baseline for escalating therapy, where a number of high-risk biomarkers, including circulating tumor DNA, glycolytic tumor volume, gene expression profile, and p53 mutation are all considered. Patients are receiving a standard of care therapy for one cycle, but anyone with a high-risk factor is then escalated to receive, in addition, the bispecific CD20 CD3 monoclonal epcoritamab as a way to try to overcome that risk. Okay, we talked about the baseline factors. Now I'd like to talk with you about the monitoring of circulating tumor DNA and learning from some of our technical challenges. And one of the first studies that we did was to look at a group of 15 patients with diffuse large B-cell lymphomas treated with curative intent. And the first 14 of those 15 patients were reported at the American Society of Clinical Oncology based on this spider plot. Those 14 patients are depicted by lines here. Each patient is a set of dots connected by a line. And these lines measure circulating tumor DNA levels relative to the start of therapy at day 0 with a curative intent induction chemotherapy like R-CHOP. And the patients are colored according to the ultimate radiographic responses per Lugano criteria. Whether we achieved a home run, a complete response in green ultimately, or progressive disease in red, or intermediate outcomes in yellow or orange. And what you will notice is something striking. Even though the time is measured in days, we can quickly distinguish the patients in whom we succeed from the patients in whom we fail. In fact, by just looking at 100-fold drop, 2-log reduction in circulating tumor DNA, by the second day of the induction therapy, we could define a threshold to then test to see how this concept would advance to other patients. And these were the results of doing so, in borrowing language from the CML and Abl kinase inhibition. An early molecular response, a 2-log drop after 1 cycle, was very strongly predictive of the likelihood of a radiographic response, ultimately as depicted in the waterfall plot at the bottom, much beyond the original 14 patients here. And this now, if looking at event-free survival, was much more strongly associated with treatment failure, with a hazard of 6.5 in the first cohort and of a hazard ratio of 10 in the second cohort. And now this result has now been replicated by a number of other groups using similar technologies for monitoring. In fact, one example is this clinical trial by Roche evaluating a 2-log drop after 1 cycle of therapy, where patients who don't achieve this milestone are then escalated to receive glofitamab, the bispecific antibody similar to the prior therapy, that I mentioned from the British trial to see if this adverse risk of not clearing DNA with traditional chemotherapy can be overcome by addition of a bispecific. And we eagerly look forward to what this trial might show, but showing the context of what early responses may look like. I wanted to put this slide forward to depict the challenge that I mentioned to you, and that is we have focused on what we can see, which is what sticks above the surface in the circulating tumor DNA that we observe, but a substantial fraction of our patients, the detection is not good enough to see the residual burden, and the iceberg lies below the surface. In fact, I wanted to depict that. Here are two key studies, the JCO paper that I mentioned to you by David Kurtz, and another key study about 10 years ago from the NCI by Mark Rashevsky and colleagues that showed these striking Kaplan-Meier curves for early molecular responses as predictors of poor outcomes. And you can see that the patients in blue who achieve molecular responses, of course, do much better. But if we count the number of patients who fail in that blue group, we have about a 20% event rate. And given the number of patients in that group, in fact, more patients have failures in that blue group than in the red group. So we need more sensitive approaches to see below the surface of the water if we want to use this to de-escalate therapy at later milestones, especially. So how might we get there? One approach that was led by David Kurtz in our group was a new technology to overcome that problem using phased variants. So I mentioned to you CAP-seq and immunoglobulin sequencing, where we follow one typical clonotype of VDJ, and we have this problem of the tip of the iceberg. But a large part of that problem relates to not having enough DNA from a given blood sample, but a lot of the other problems relate to the background error rate, mutations that are technical and not biological. So an approach to overcome this is to use phased variants, mutations that are clustered, where instead of one mutation on a given molecule, you look at two or more mutations that co-segregate on individual DNA strands, and the likelihood of observing those DNA mutations together at random is much lower, and that allows you to then look below the tip of the iceberg in analytical limits of dilution that can achieve tumor fractions down in parts per million because of the sublime low error profile of such mutations. Now, this is analytical and technical, but how likely is this to be real, and how practical is this for patient monitoring? How often do these mutations occur in lymphomas? So looking across the genomes of our patients with lymphomas in these Manhattan plots, where the genome is displayed on the x-axis from chromosome 1 to the sex chromosomes on the far right, and the y-axis depicts the frequency of these phased mutations, we find that there are spikes or tall buildings that reflect the prevalence of these mutations in all our lymphomas, where hundreds of mutations can be found in phased relationships in stereotyped parts of the genome, including the immunoglobulin genes and other oncogenes characteristic of individual histologies like the BCL6 gene in large cell lymphomas, BCL2 in follicular, MYC and ID3 and Burkitt, and so on. In other tumor types, like solid tumors, you can find the same mutations in phase structure, but they have a much less stereotyped architecture. So to recover them, you need to use whole genome sequencing to identify personalized mutations and build custom panels. I will not discuss that today. I will use the idea of trying to find the tall buildings here and monitor mutations using fixed panels. So I wanted to focus on an example patient. This is a patient of mine, a 55-year-old woman with advanced large B-cell lymphoma who achieved a PET remission, but unfortunately relapsed roughly 450 days after therapy. And using CAP-seq, we were able to detect her disease about 5 months before her relapse. in the blood. But of course, unfortunately, we were unable to detect her MRD through the course of induction therapy and at 2 time points after completion of therapy. And in part, as you can imagine here, this is the tip of the iceberg problem that I was depicting here. So if we take this patient and monitor the same patient with a more sensitive method, you can find that, of course, she had disease at all the time points. They were falsely negative when we missed them. And a sensitive method, because it has a lower detection limit, can recover all of these and now accomplish roughly a year of lead time before her radiographic relapse in a way that we might intervene on. Of course, that equals n equals 1. What about this in a broader group of patients? Here's a group of 88 patients where David applied the same idea. About 52 patients had undetectable disease using our older technology. And when applying the newer method, how might we do? The patients with undetectable disease had about 20% failure. And if we take those patients with undetectable disease and said, who could be detected by this newer method, you can see here that those patients who had residual disease did more poorly than those who did not. This is at the interim in the middle of therapy, and the same concept can be done later. What about the idea for de-escalating therapy? This is an interesting case, a patient of mine with stage 4 large B-cell lymphoma who underwent induction chemotherapy with EPOCH-R chemotherapy, and after 1 cycle receiving this therapy, experienced such toxicity that he opted to discontinue therapy against medical advice due to toxicity to go home with hospice. Now, this patient miraculously achieved a curable outcome in that he's more than 8 years from his diagnosis with only 1 cycle of therapy. And we looked back to see what happened because we typically require 6 cycles of such therapy. And we observed that this patient achieved MRD negativity after 1 cycle. So if that's true for this one patient, what's the likelihood that it's true for others? And there are now several clinical studies, including a study at Columbia University that is asking this question in large cell lymphomas, and a similar study in Hodgkin's disease at the University of Washington in Seattle for de-escalating therapy. These are results of that same concept, taking the N of 1 at the end of therapy, having been shown at conferences and now under review at key publications. This is work from Stanford, but similar work from multi-institutional studies have been led. This is a study led by the National Cancer Institute in the US, looking at end of treatment MRD in diffuse large B-cell lymphoma across a number of frontline studies. So this is the first validation of that result, and showing that this is strongly prognostic in both patients who have PET positive on the right and PET negative on the left. So circulating tumor DNA is capturing something that PET cannot in these patients, as depicted by these Kaplan-Meier curves. Another study led by our colleagues at UC Irvine and Samsung University looked at a real-world population from Korea, looking again at the value of PET-CT and ctDNA MRD in a real-world population. And you can see here the overall survival of these patients relative to PET-CT when using ctDNA MRD and the phase-seq strategy that I mentioned earlier. And very recently, our Dutch and Belgian colleagues showed us results from the large HOVON national study looking at ctDNA, PET-CT, and IPI at the end of therapy. And these results were shown at both EHA and the Lugano meeting and the ASCO meeting, all showing this pretty striking result for MRD status at the end of therapy. So that is in the front line. What about in the relapse setting after failure of chemotherapy? This is a clinical trial led by Bristol Myers Squibb that led to the approval of liso-cel for relapse disease when comparing liso-cel to this historical standard of care, high-dose therapy and autologous transplant. As you may remember, these Patients were adults with refractory large cell lymphomas that recurred within 12 months after frontline therapy, were transplant eligible and had adequate performance status. And these same patients were then evaluated for MRD as part of a pre-planned analysis, exploratory analysis, and this was done at Foresight Diagnostics. And these results were shown at the American Society of Hematology meeting, similar to the spider plots that I showed you before, now in the context of relapse, patients achieving CR with a single infusion of CAR T cells dramatically improve their MRD levels, whereas patients who don't achieve PET CRs seem to have a modest decline in their MRD, but not to clear disease. And when comparing the tendency to clear MRD, what was observed was that overall MRD rates were substantially higher in the experimental arm as compared to the historical standard of care, 62% versus 38%. And when comparing those rates to the primary endpoint of the trial, they were quite consistent with the primary endpoint, suggesting the ability to accelerate these drug approvals using early measures as early as 15 days after CAR infusion. Now, these results in the US led to changes in our NCCN guidelines, where patients receiving induction therapy who are getting end of treatment assessment by PET CT, a significant minority of these patients, 25%, have incomplete responses, but we know that PET CTs are only about 50% of the time consistent with ultimate radiographic results. So in those patients in whom such results are observed, we typically require confirmatory biopsies before we escalate therapies. And unfortunately, for a significant fraction of these patients, biopsy is challenging or technically not feasible. And based on these results, the NCCN has now recommended use of sensitive MRD for as an alternative to tissue biopsy for adjudicating radiographic results before choosing second-line salvage therapies. Okay, but we know today that using induction therapy, 3/4 of our patients achieve radiographic complete responses, but still have a 30 to 40% risk of relapse. 1/4 of our patients achieving complete responses, and we require tissue biopsies. And as I mentioned to you, now using ctDNA, those who have negative results go back to the routine surveillance, and those who have positive results, we escalate therapy. And the question is this patient population in whom there's a 30 to 40% risk, can they be identified earlier? Why might we want to do that is because of results like this, where improving on induction frontline therapies is proven especially difficult. In lymphomas, it took us more than 2 decades before we got a new frontline induction therapy, despite trying in more than a dozen trials and enrolling tens of thousands of patients on these trials. So we might be able to accelerate approval of drugs based on earlier measures of disease before relapse. And one such trial is the ALPHA3 randomized trial, where patients who get in curative intent frontline therapy, who achieve a response, but in whom there is persistence of MRD, are then randomized to either a standard of care observation or intensification with an allogeneic off-the-shelf CAR T cell therapy after lymphodepletion. And this trial's accruing and will hopefully show us whether learning bad news early using circulating tumor DNA can be used to inform a therapy decision that might improve outcomes. So I hope to have convinced you so far that baseline ctDNA levels can predict outcomes in aggressive lymphomas, that early measures of response after 1 or 2 cycles much more strongly predict treatment failure, and several trials are using risk-adapted strategies to mitigate this risk. At later time points, especially at the end of treatment, the assessments challenge us because of the tip of the iceberg problem that I mentioned to you that requires significant improvements in technologic sensitivity beyond first-generation assays. And now multiple prospective studies are showing that such assays can work in the real world and in various induction regimens. And it's now been proposed that circulating tumor DNA should be integrated as a standard component of response evaluation in diffuse large B-cell lymphoma, and whether practice can be changed using this measurement will, of course, need randomized evidence like the Alpha-3 trial that I just mentioned to you. Now with that, I'd like to switch gears and focus about diagnosis and lymphoma classification, and to talk about some emerging ideas that I think hold promise, but this is more leading edge and emerging, so I wanted to just highlight that before starting. We talked about the timeline of a patient, and at baseline, we are talking now about the red box, genotyping and classification starting from the blood. In patients with diffuse large B-cell lymphoma, several key studies show us now that the genetics of the disease is quite complex, and a number of genetic groups can be defined by somatic mutations when starting from whole genome or whole exome sequencing. And these have these names as defined in these acronyms here. And a number of years ago, we took the strategy of saying, could we detect these same subtypes in the blood? For example, as might inform intensification strategies or acceleration strategies led by our colleagues from China within the guidance trials, where the mutations inform addition of therapy selection. This was feasible. In fact, we found about 85 to 90% of patients could be genetically classified, that the expected pattern of genetic risk could be recovered from the blood, including in individual diseases like germinal center subtypes when dividing patients by mutations. So this could be done, and a large trial, the Polarix trial, and the CAPS-seq technology was also tested by our colleagues from France, Fabrice Jardin and colleagues, that showed about a 75 to 80% concordance of this strategy from the blood with a tissue-based characterization using a large population of randomized patients. Another example of this was within the study of obinutuzumab and lenalidomide for diffuse large B-cell lymphoma, where patients could be classified. About 60% of the patients could be genetically allocated. And so this shows real-world application of these genetic-based classifications in patients receiving investigational therapies for lymphoma. What about trying to measure heterogeneity? As we know, as Dr. Mohty mentioned, the blood is a window into diverse tissues that can harbor disease. Jordan Goldstein in our group has been looking at the blood and its discordance with tissue, comparing blood with any single tissue, and he observed some very striking things, which is patients could have high or low variation as measured by the root mean square error of the mutation fractions when looking at the blood on the y-axis or tissue-based burden, as though the blood was measuring anatomic heterogeneity that could not be seen in any given tumor deposit. And in fact, he could validate a high root mean square error as a bad prognostic factor in multivariate analyses for outcome. And he has observed this now in multiple lymphomas, suggesting that blood versus tissue comparison can capture things that we cannot see in any single compartment. What about subtyping? So we're used to liquid biopsies for genetics, as I mentioned to you, but the blood can also be used for measuring gene expression. And this can be done both directly from RNA, and our work from Monica Nesselbusch depicted here using cell-free RNA, and the rare-seq method is one such way. The other strategy is to use inferred gene expression from DNA fragmentation, and this is work led by Mohammed Esfahani in our group originally, and pushed further by Yurik Mutter in the group. And the basic idea is that genes that are highly expressed have high levels of fragmentation at the beginning of the genes or the transcription start sites. And so if we carefully select genes that we are interested in and focus on those starts of gene expression for the pattern of fragmentation of DNA, through DNA, we can predict RNA, and in doing so, can we subtype disease? We have done this now for 11 lymphoid cancers across a range of histologies, from follicular large cell, CLL, Hodgkin's lymphoma, T-cell lymphomas, mantle cell lymphomas, myelomas, Burkitt, and beyond, and targeted a few megabases of the genome to see if we can subtype disease in this way. And the first results were shown at ASH in a group of about 400 subjects, 368 subjects, which showed us that we could see the expected patterns of expressions that were used to CD19 being expressed in non-Hodgkin's lymphomas, but not Hodgkin's disease, CD30 being expressed in Hodgkin's disease, but not B-cell lymphomas all that often. But more importantly, that the expected pattern of gene expression for each disease, Hodgkin's disease, large cell, follicular, mantle cell, as measured in the x-axis, was correlated with the mutation levels of the somatic genes that I mentioned to you before in each case. So epigenetic and genetic methods for measuring disease burden were strongly correlated, independent of histology, which shows us that there's a promise here for measuring disease through each method. And in fact, when trying to divide these diseases, you could use gene expression from the blood to achieve reasonably high performance classification for each histology, including for difficult problems. For example, the transformation of follicular lymphoma to large B-cell lymphoma, we could detect a significant fraction of these cases. The accuracy of these methods was reasonably high. Overall accuracy of getting the histologies correct in the top three was 95%, varied by subtype from Burkitt, et cetera. These are unpublished results that we're hoping to share with you soon. So I hope that in the second part, I have convinced you that liquid biopsy strategies also allow us to reliably classify and recognize subtypes. It's an open question whether these methods can allow non-invasive de novo discovery of novel, unrecognized previous lymphoma subtypes, and I hope to share those results with you later. So how do I think about the timeline of applications of MRD for drug development? I think today we are already using treatment based on ctDNA and key clinical studies that are investigating the activity of drugs for internal decision making and make no-go decisions based on MRD responses. I showed you some key examples of using MRD status for patient selection, and several key clinical trials have shown us how to do this in leukemia, for the ALL, for mantle cell lymphoma, and for follicular lymphoma. But I think an emerging idea is the idea of using MRD and its clearance as a surrogate novel endpoint in borrowing from similar ideas in CML, CLL, and myeloma. And I hope that we can all work towards this. So with that, I like to come back to the discovery of these molecules. I didn't learn about these molecules as a medical student or a resident, but they were discovered a long time ago in the 1940s by two French scientists, even before the structure of DNA were solved. When they published their monograph, they finished this monograph with the sentence that I had Google translate for me, saying that they will return in a future work on the case of neoplasms. I wish these scientists were here to see the revolution they started with DNA, because we've learned quite a bit from their discovery, and I hope we can learn more together. With that, I'd like to thank the people who led this work, members of my own lab, Max Dean's lab, our patients, our key collaborators, our funding sources, and thank you very much, and take your questions.
Thank you very much, Professor Alizadeh, for really an inspiring, amazing, comprehensive webinar. It's quite incredible, you know. I couldn't imagine the level of advances we've seen in the field. So we have a few questions. I think we can spend maybe 5 minutes maximum. Otherwise, we'll spend the whole day. We have one question about the sensitivity measurement of circulating tumor DNA compared to PET-CT. And the other question we have is about, despite all the positive and convincing data you have shown, why the use of CT DNA is not part of routine clinical practice today? What are the barriers?
Yes, both are good questions. So the clinical sensitivity versus PET-CT, I think the two studies that I mentioned to you from Samsung University and from the HOVON Dutch-Belgian cooperative probably are the best studies to look at that because they had a routine radiographic assessment. And in both populations, there was substantially higher sensitivity than PET-CT for residual disease. Even though there were roughly similar rates of positivity for PET and ctDNA at the end. I don't remember the precise numbers from both studies, but there was dramatically more risk of recurrence captured by ctDNA than by PET-CT because of the false positive problem and also the false negative problem for PET-CT. If the person asking the question can send me an email, I'll pull out the 2 slides from those presentations and send them the exact percentages for the comparisons. With regards to the second question about routine use of ctDNA MRD, I think it touches to the key question. So aside from the case that I mentioned to you within the NCCN guidelines, which is just about a year old decision, or 6 months or a year or something like that, the routine use has not been as widely adopted as you might think, in part because we have not had evidence to show us beyond, the prognostic value, what should you do with this information. So I think in the scenario that you have a radiographic result that's difficult to adjudicate, it makes quite a lot of sense to avoid a biopsy to discern whether you have disease or not if you have a better test. And I hope that becomes routine. And I anticipate that our lymphoma response criteria will ultimately have ctDNA become part of it. They have not yet. And we have to democratize access to these technologies across our trials and to be able to do that routinely. But of course, we then need to see evidence that taking this information can give you something that you can act on. And for that, we need randomized trials to show that early intervention matters, that learning prognostic information can inform a therapy decision beyond the
Does this mean your suggestion is that we need to run similar trials what we have done 15 years ago with PET-CT to establish the role of ctDNA? Because obviously when PET-CT was developed, I don't remember that we were using PET-CT to make a decision
I
after
think you're
2
right.
cycles
I
of
think you're
chemo.
right. You're right. The original trials, the Wade paper, which Bruce Chesson showed us at the Kaplan lecture that he gave in Lugano a few weeks ago, was only about 50 patients, and there was no randomized evidence, but it showed us how much better PET-CTs are than CTs and lymphangiograms. We used to inject dyes between the toes, right? And we have a better tool, and you're right. ctDNA is a better tool than PET-CT, and if it's true that it's better than PET-CT, should it replace PET-CT? I think that's the question. If it's accessible, affordable, and some would argue yes, but I think it's difficult to change many minds when we have this. I think these technologies can reach patients and complement one another, but ultimately, beyond assessment of response, we need to see that you can change something based on it. So I think both are good to have. I hope I answered your question.
Yeah, absolutely. Thank you. One practical question we have, maybe I have missed it in your webinar. How much, what's the volume we need to study ctDNA? This is a question from Dr. Shah.
Pardon, I missed the question. Can you repeat
Yeah.
it one more time?
What's the volume of blood you would need to test for
Yeah,
ctDNA?
so most of the studies that I showed you here today have used a median of 4 ml of plasma, which is one Vacutainer, a 10 ml blood collection tube, to guarantee 32 nanograms of DNA from about 90% of patients. That is the typical ones. Some studies, like the Alpha-3 trial, who are making a critical decision and cannot have any failure and so on, have collected more. I've collected 3 tubes of blood for a fallback. There are some trials in colon cancer that have collected 6 tubes of blood at a given milestone for a decision. The New England Journal trial, the dynamic trial that showed the non-inferiority of MRD for colon cancer monitoring, was such a study as a large blood volume was collected. But those are the ranges. It's not an apheresis or anything like that. It's usually 1 to 4 tubes of blood. Most of the studies I showed you was using 1 tube.
So relatively easy and non-invasive, which obviously
Yes.
we should push for it. Is there any specific ctDNA marker that can correlate with tumor progression, for instance, a specific sequence, whatever?
Yeah, this is a very good question, and something we spent a fair amount of time on in the genetic subtypes that I mentioned to you. We and others have found that there are high-risk genotypes that measure specific risk groups, like the activated B-cell lymphoma subtypes, like the MCD subtype or the EZB double hit subtype, can predict poor outcomes at the beginning. Basically, some histologies are bad, certain genetic risk groups are bad. But comparing the magnitude of those hazards at baseline compared to the presence or absence of DNA at the end of therapy as MRD, there's not much of a comparison. Having time to tell you whether you have residual disease is a lot more valuable than knowing what subtype you have at the beginning. Aside from that, the heterogeneity measure that I mentioned to you, which is to compare blood with tissue and to see what you see in the blood that you don't see in tissue, is another way to identify unmeasured disease burden that reflects anatomic heterogeneity that contributes to outcome. In that analysis, it seems like the targets don't matter so much, and they largely reflect somatic hypermutation that targets the rest of the genome. And if you see discordance between blood and tissue, it tells you that you have unmeasured disease.
One last quick question and short answer because we are
Yes.
beyond our time. From Dr. Frederick Mayer Wentrup, how do you act on post-treatment rising ctDNA levels in your patient, and does this impact the monitoring schedule? Would you modify treatment?
Yes. So the specific example that I mentioned to you within the NCCN guidelines of using ctDNA, for example, to adjudicate a radiographic result that's equivocal. In the United States, patients who have persistent or progressive disease within 1 year of induction therapy are eligible for CAR T-cell therapies, with 2 of them approved in that context. And so if we cannot biopsy those patients safely and we get an MRD result that's positive, that shows disease and helps inform the therapy immediately. We should remember that the ZUMA-7 trial and the TRANSFORM trial did not absolutely require biopsy confirmation. So patients were treated with radiographic results, a significant minority of the time. So having ctDNA adjudicate that result gives us even more evidence that these patients might benefit for a CAR T-cell therapy. So that's the kind of situation in whom that level, that MRD level, but of course, if the patient meets the criteria for that intervention.
Thank you, Professor Alizadeh, and thank you all for joining us into this insightful IACH webinar on liquid biopsies in lymphoma. I believe today's discussion highlighted the transformative potential of liquid biopsy technologies in improving diagnosis, risk stratification, and disease monitoring, while also recognizing the current challenges in standardization, sensitivity, but also clinical routine integration. However, we've seen in the conclusion of Professor Alizadeh, the publication from France from 1947, and research is progressing rapidly, and these tools will become more refined, and these liquid biopsies are poised to become an essential component of precision medicine in lymphoma and cancer in general. We look forward to continued collaboration and innovation in this exciting field. Until then, thank you for your engagement and see you at our next ICH event. Wherever you are, please stay safe, keep well, stay inspired. This is the International Academy for Clinical Hematology around the globe and across the hematology field. Thank you.